I think you mentioned VHL, right? I think that's definitely the most common one, given the VHL gene, as we know, right, is one of the most common causes for the VHL syndrome. But, I think another one that, we know is Birt-Hogg-Dubé, and that's something that we can go over. But again, we're not going to, I think for the sake of time, we can't go over all of them, but I know we're going to talk about HLRCC in a little bit, right? So give us a little bit of, give us a primer for HLRCC. Like, how is that, what are the clinical manifestations? What's the genetic basis for that as well?
Sure. So HLRCC, it's another autosomal dominant syndrome. It's characterized by an alteration in FH, or the fumarate hydratase gene.
Hmm.
Its hallmark feature is that affected patients can present with highly aggressive RCC variants. It's now termed FH-deficient RCC. It's previously known as HLRCC-associated RCC as well.
Hmm.
And these patients can present with early metastases from smaller than expected primaries. And, HLRCC, from extrarenal manifestations, is also associated with painful skin cutaneous leiomyomas or
Hmm.
benign uterine leiomyomas in females.
Hmm.
And so you'll see these patients will present from a dermatologist's office who's really picked this up, and these painful cutaneous leiomyomas, or to a urologist with a renal mass in a young patient. It's not uncommon to note a strong family history of lethal RCC, and unfortunately, it's also not uncommon that they present with locally advanced or metastatic disease. We have a number of patients here who we follow because their child was actually diagnosed with metastatic or advanced disease. And it's very heartbreaking to hear, but fortunately, as we know more about this and diagnose this earlier, we can hopefully try to curtail that.
That makes sense. And I think, something that I remember reading is these patients have papillary disease, right? So papillary type 2 disease. Now, I think we're calling FH deficient now. And I think part of the reason was, there's type 1, and that was a pretty clear histologic variant, right? And then this type 2 was like a bucket. It was like a very broad bucket of whatever that didn't look like type 1. And so it was a very heterogeneous group. But I think now we're able to, with genetic testing and better better tools, we're able to kind of narrow down exactly what we're talking about. Right? So I think it's considered a type 2 papillary tumor, but it's actually really FH deficient. Is that kind of your understanding of how that would work as well?
Yeah, that's absolutely right. Type 1, papillary type 1 is a distinct entity. Papillary
Yeah.
type 2 was a wastebasket term for a number of
Yeah.
different papillary tumors, which is why
Right.
the WHO and a number of pathologists have really done a lot of good work in subcategorizing this with
Yeah.
molecular characterizations. So HLRCC associated RCC, or
Hmm.
now called FH deficient RCC, because there are some patients with somatic FH alterations that
Yeah.
act a lot like this. They get lost in the weeds here, but regardless, they've made separate characterizations to really further define this, because these are histologically a little bit different, molecularly very different, and we think their sensitivities to different treatments are also different as well.
Yeah.
And the first step is defining it, and real kudos to the pathologists really kind of making a big effort here.
When we talk about HLRCC, right? I mean, in terms of the major diagnoses of clinical manifestations, you mentioned obviously lethal RCC that runs in the family is one of them. And the other one is maybe a younger age. And obviously, you mentioned cutaneous manifestations. Are there any other major ones that we should look out for in clinical practice that would be that's important?
So when you look broadly for
Yeah.
hereditary kidney cancer, I think there's three major, we call them enrichment factors, that we should take into look and take into
Hmm.
mind that should raise your suspicion that someone might be affected by one of these syndromes. And these three are young age, bilateral or multifocal tumors, and a
Okay.
family history of RCC. So we
Hmm.
talk about young age. Generally, the accepted cutoff is 46 years or younger. Having multifocal tumors or more than one tumor on a kidney or tumors on both kidneys is another risk factor.
Sure.
And lastly, having a first degree or second degree relative with RCC is also another risk factor. You
Okay.
know, our group is looking at the NCI experience at this right now, and we found that each of these factors is additive,
Yeah.
especially in the setting of positive family history. And regardless, outside of that as well, knowing about these various manifestations of these syndromes can help put the diagnosis of hereditary cancer on your radar. So
Yeah.
if you have multiple AMLs and angiomyolipomas, that may key you into tuberous sclerosis, et cetera. And it really will get you keyed in to say, maybe this patient needs to see a genetic counselor. You
Mm.
don't have to memorize this laundry list of different things that are here, but rather having a basic understanding of what things can be present with other things as well. And understanding these three main risk factors can really tell you, should I send this person to a genetic counselor and have them help me identify what's going on here?
Yeah. I mean, I've done my fellowship at the NCI, I just know the importance of a genetic counselor. They are
Right.
just such an invaluable part of that multidisciplinary team. And you're obviously working there. You work very closely with them, and that's a great resource for both patient and physician.
Absolutely.
When we, now that we're, for someone with a diagnosis, right, of whether it's VHL or HLRCC or, even VHD, right? So I think something that people tend to always point to is, well, there's a lot of work at the NIH many years ago, Dr. Linehan kind of leading that charge saying, tumors of X amount of size probably need to get some type of treatment, right? And I think for VHL, it's around 3 centimeters, but help us kind of understand what that treatment guideline is, how that number really means anything to patients, and maybe what the surveillance protocol would change either after treatment or maybe for younger patients.
Okay. So I think we can talk, when we talk about surgical management of these patients, I think you can put in 2 baskets. So the one we can first talk about, we can prototypically talk about a VHL patient because a lot of the things can translate to most other syndromes.
Yeah.
Say this right now as a caveat, it's specifically what I'm going to talk about right now will not apply to HLRCC or SDHB patients. I'll mention that a little bit later because their tumors are much more aggressive and we manage those differently.
Sure.
So you mentioned Dr. Marcin Linehan here at the NCI. He both discovered the VHL gene and coined that 3 centimeter rule that you mentioned. And this came about an early assessment of VHL patients in which long-term follow-up showed that that patients that had surgery before their masses were larger than 3 centimeters did not develop metastatic disease. And over the years, this has continued to hold true. And so this is what we have clinically used to determine when it's time for surgery. And the questions that I frequently get are, well, how do you do 7 to 10 partial nephrectomies if these tumors are present with 8, 9, 7 tumors present in each kidney? And how do you end up with an intact kidney at the end? And also, how can you do this without such a prolonged ischemia in time where the blood flow of the kidney is cut off that you don't have poor renal functional outcomes? So in order to do this, the key points are that we perform what's called a tight enucleation of the tumors. This allows us to maximally preserve nephrons. And so we actually peel the tumor off of the surrounding renal parenchyma that's present there. It's also important in preserving the renal functional outcomes, as data from our and others have shown that the volume of nephrons removed during a partial nephrectomy is one of the biggest predictors of renal functional changes after surgery.
Okay.
The next thing is when we don't violate the nephrons and the renal parenchyma while doing an enucleation, there's considerably less bleeding than what is noted in a standard resection. So this allows us to resect almost all but the deeply endophytic tumors and what's called off clamp or without renal ischemia. There'll be bleeding from the vessels that supply the base of the tumor, but these can be managed effectively and quickly with deep or norephy sutures. So therefore, we save ischemia for deep tumors that are purely endophytic within the renal sinus or within the main renal hilar vessels.
Okay.
Lastly, we try to remove all accessible tumors present on a kidney. So generally, all exophytic tumors are resected regardless of size. We use intraoperative ultrasound as it's more sensitive in finding tumors small tumors missed on conventional imaging. And sometimes endophytic tumors require a judgment call based on the patient's clinical situation when they're very small.
Sure.
Our goal, we achieve oncologic control while we maintain good renal function and ideally reduce the number of lifetime surgeries. And this kind of helps do that.
And again, I want to make sure that we understand that's for VHL, right? So you're probably going to talk to us about something that's a little more aggressive than VHL is HLRCC and SDHB, right? Those are different entities, different genetic basis, and we should manage them in a different surgical manner as well.
Correct. What we talked about affects VHL, BHD, and other tumors that have less aggressive renal masses and renal phenotypes there.
Yeah.
But when we talk about the more concerning ones are the aggressive tumors. And the 2 in particular I want to mention are HLRCC, like you mentioned, and SDHB deficient RCCs. Interestingly, both of these syndromes are characterized by changes in the enzymes that affect the Krebs cycles. We can wax poetic about that, but they eventually produce locally aggressive tumors. And the strategies to manage them are very different. So when you talk about HLRCC-associated RCC or FH-deficient RCC, it's likely one of the most aggressive variants that we know. We've noted a number of smaller tumors in the 2 or 3 centimeter ranges that have led to locally advanced disease or metastatic escape. And our institutional experience here has shown very aggressive T3 and T4 disease in patients with centimeter or smaller tumors, which overall taught us that these tumors should not be surveilled. Once there's a concern for a lesion being present, it should be resected, even knowing that there's a higher likelihood of a false positive benign lesion being resected instead. So we will resect very small tumors, even those that are a centimeter or less in size. And to identify these ones, the proper imaging is key. We're firm believers in MRIs to assess patients with HLRCCs. Ultrasounds do not have the granularity of detail to do this, and a multiphasic MRI gives more information than a CT. We're looking for enhancement, but at the NCI, we've reported that a majority of these tumors, greater than 80% of them, also have very restricted diffusion. Therefore, high p-value imaging in your MRIs can be very helpful here in risk stratifying a lesion to say if it's worthwhile to pursue surgery for it, or if it's truly a concerning lesion or not. At time of surgery, we know large, wide margins are important. For most tumors, we aim for at least 1 centimeter on all sides. It's paramount to ensure that the tumor is not violated, as any spillage of direct tumor content or fluid from a cystic tumor has a very high likelihood of locally recurrent disease within the retroperitoneum or the peritoneum. Therefore, even though most of us do most of us here do a vast majority of robotic surgery at the NCI, we recommend that these resections are performed in the open fashion to ensure that no violations are present and we have nice large margins.